Assalamu alaikum. Good morning, ladies and gentlemen. My name is Amani Abdurrahman, an Associate Professor of Pediatrics at Zaim Al-Azhar University. Our lecture today is going to be about lymphomas, namely Hodgkin and non-Hodgkin lymphoma. To begin with, the best way to go together over the lecture is to listen to the recording while you are looking at the slides, as I usually have them open in front of me while I'm doing the talk. So let us get started. The objectives of our talk today is going to be about definition, what is lymphoma, what are the types of lymphomas, how do we stage lymphoma, what are the clinical features, and how do we diagnose a patient who's suspected to have lymphoma, and how do we treat these patients. What is lymphoma? It's a type of malignancy that originates from lymphocytes which start to grow out of control. The disease is named after an English physician, Thomas Hodgkin, who first described it in 1832. Hodgkin lymphoma is rare before 5 years of age, and the disease has a bimodal curve for presentation. That is to say, it affects two separate age groups. First peak at the age of 15 to 35, and a second peak after the age of 50. Hodgkin lymphoma is more common in boys, and both EB virus and HIV/AIDS may be involved in the pathogenesis. The central histological feature in Hodgkin lymphoma is Reed-Sternberg cell seen in the lymph nodes, and this cell consists of large binucleated cell with a prominent nucleolus, and the shape of the cell resembles owl eyes shape, and that is why it is called owl eyes, or a two mirror image nuclei. The cell is having a distinct nuclear membrane and abundant cytoplasm. In this slide, you can see this binucleated cell with a prominent nucleoli. Hodgkin lymphoma has 4 histological subtypes: lymphocyte predominant, nodular sclerosing, mixed cellularity, lymphocyte depletion. The commonest type is the nodular sclerosing, seen in about 50 to 70% of the cases. And this type is seen more in girls, in contradistinction to Hodgkin lymphoma, which is usually uncommonly seen in boys. This nodular sclerosing type, composed of large nodules showing classical Reed-Sternberg cell, set in a background of reactive lymphocytes, eosinophils, and plasma cells within fibrotic and sclerotic tissue. The mixed cellularity type, which is a common subtype, seen in round about 40% of the cases, there are mixture of cells, namely Reed-Sternberg cells, lymphocytes, eosinophils, plasma cells, and histiocytes, but without sclerosis. This type is associated with EB virus infection and is commonly seen in the immunocompromised patients. The other type is the lymphocyte predominant. It's a rare subtype seen in less than 20% of the cases, but has the most favorable prognosis. The lymphocyte depletion is seen in less than 10% of the cases. In it, there are large number of Reed-Sternberg cells with few lymphocytes, and it has got the worst prognosis. Clinical features of Hodgkin lymphoma. Mainly, the lymphoma arises in the lymph node, and the commonest site is the cervical lymph nodes. It is extranodal in less than 1%. There are as well mediastinal lymph node enlargement, causing tracheal and bronchial obstruction, and due to pressure symptom, the patient can present with cough and tachypnea. Bone marrow involvement can lead to pancytopenia, that is to say the patient is having low levels or numbers of red blood cells, white blood cells, and platelets. Hepatobiliary obstruction, and the patient can present with jaundice. Spinal cord compression can lead to paraplegia. Hodgkin lymphoma has association with immune disorders, namely autoimmune hemolytic anemia, autoimmune thrombocytopenia, nephrotic syndrome, and the commonest type of nephrotic syndrome associated with Hodgkin lymphoma is the minimal change glomerulonephritis. Patients are assigned as A or B category based on the absence or presence of the three following symptoms: fever, night sweat, and weight loss of more than 10%. So if the patient is having any of these symptoms, he is said to be having a B category. And if he's not having any of these symptoms, he is an A category. So A for absent, B for present, and this is how I use to remember it. In staging, we use an Arbor staging classification for both Hodgkin and non-Hodgkin lymphoma. Ann Arbor is named after Ann Arbor, Michigan, which is a city in Michigan state. This is a state in the Midwest region of the United States of America. And this is where the committee met in 1971 to approve this staging. It has got 4 stages. In stage 1, there is involvement of a single lymph node region, mostly cervical. Stage 2, involvement of 2 or more lymph node regions on the same side of the diaphragm. Stage 3, involvement of lymph node regions above and below the diaphragm, which may include the spleen. Stage 4, disseminated involvement of 1 or more extra lymphatic organs, for example, the liver. Diagnosis is by doing an excisional lymph node biopsy, and this is the definitive diagnosis where you can see the Reed-Sternberg cell. Blood test looking for evidence of anemia, thrombocytopenia, and leukopenia. Chest X-ray looking for mediastinal involvement or enlargement. CT scan, MRI scan, and PET scan. With PET scan, the sites involved with lymphoma. They use a special dye in this PET scan, and these dyes light up very brightly, enabling accurate imaging. In the past, doctors used to do lymphangiogram laparotomies to look for tissue and the organs involved, but this is no longer used. Bone marrow biopsy, liver function test, renal function test are all part of the workup and the diagnosis of Hodgkin lymphoma, but the definitive diagnosis is by the lymph node biopsy. In the treatment, there are 3 modalities: chemotherapy, radiotherapy, and stem cell transplant. There are different protocols used in different centers, and I'm not going into the details of this. The prognosis, generally it is good. The 5-year survival rate in stage 1 can go up to 94%, and it goes down to 78% 5-year survival rate in stage 4. Now it is time for the non-Hodgkin lymphoma. Non-Hodgkin lymphoma is seen more commonly than Hodgkin. It occurs in a younger age group, and it carries a less favorable prognosis. So it is more common with a less favorable prognosis with younger age group. It has low, intermediate, and high-grade types. That is to say, the high grade is diffuse and rapidly growing, and unfortunately, children tend to have the high-grade type. Non-Hodgkin lymphoma associated with multiple congenital immune deficiencies and acquired ones, like the HIV/AIDS, which is acquired immune deficiency, and in the congenital type, it is associated with the Wiskott-Aldrich, the severe combined immune deficiency syndrome, and the ataxia-telangiectasia. And I'm not going into details of these congenital immune deficiency syndromes. The non-Hodgkin lymphoma has three main types in children: the lymphoblastic lymphoma, large cell lymphoma, and Burkitt lymphoma. Few words about Burkitt lymphoma, which is commonly seen in boys in the age of 5 to 10 years. Burkitt lymphoma has two types, the endemic and the sporadic type. The endemic type is usually seen in African children, and it has got an association with EB virus in more than 90% of the cases. Usually, the endemic type affect the jaw and the facial bones, while the sporadic type, which occur, the main site of affection is the abdomen, and the sporadic type usually occurs in parts outside Africa. This is a photo of a Burkitt lymphoma child, and he's having a huge swelling on the right side, the jaw and the face. What about the clinical features of non-Hodgkin lymphoma? It is almost the same as the Hodgkin. There is lymph node enlargement. As we said, that Hodgkin lymphoma is mainly a nodal involvement, while the non-Hodgkin lymphoma is an extranodal involvement. So here we find more involvement of extranodal sites. The anterior mediastinum, patients can present with features of obstruction due to pressure symptoms like cough. Abdominal mass, as we said, there is abdominal involvement, and the patient can present with intestinal obstruction, bone pains. The lymphoma cells can involve the central nervous system. They can go to the meninges, leading to meningeal involvement, raised intracranial pressure, cranial nerve pulses, cord compression, and bone marrow infiltration. How do we diagnose non-Hodgkin lymphoma? We usually start by doing blood tests like complete blood count. We can do as well bone marrow aspiration or biopsy, diagnostic imaging like CT, MRI, or PET scan, immune phenotyping test, flow cytometry, cytogenetic studies by using the FISH test, bone scan and screening for HIV, renal function test, liver function test are all part of the workup for a patient with non-Hodgkin lymphoma. In the treatment, chemotherapy, radiotherapy is not commonly used. Actually, it is used in very limited cases, as patients with non-Hodgkin lymphoma, they tend to be resistant to radiotherapy, stem cell transplant, and there is new modality, which is the targeted therapy and the immunotherapy. In the targeted therapy, it is targeting the lymphoma cells by using monoclonal antibody therapy, a drug called rituximab, tyrosine kinase inhibitors, or by using immunotoxins, and these combine to the malignant cells and kill them. Concerning the prognosis in non-Hodgkin lymphoma, as I mentioned before, non-Hodgkin lymphoma has a less favorable prognosis. The 5-year survival rate for stage 1 is around about 80%, while it goes down to 60% in stage 4. And this depends on the subtype and the risk factor. And once the bone marrow is involved, the prognosis is generally poor. This is a slide where there is a summary and a comparison between the Hodgkin and non-Hodgkin lymphoma. It highlights on few points. Hodgkin is mainly a disease involving the lymph nodes, while the non-Hodgkin involves extranodal sites. The pathognomonic feature of Hodgkin is the presence of the Reed-Sternberg cell in the lymph nodes. Hodgkin has bimodal distribution occurring in young adults and those more than 55 years. Non-Hodgkin lymphoma can occur in children and adults. Hodgkin is associated with EB virus. Non-Hodgkin is associated with HIV and immune deficiencies syndrome, that is to say, acquired or congenital, but as well EB virus is involved in non-Hodgkin lymphoma, and this is mainly in the Burkitt's, as has been discussed before. Constitutional symptoms or the B symptoms of fever, night sweat, and weight loss can be found in both cases. And this is the last slide, the Ann Arbor staging system. I just want to say that if you see a patient being labeled as having 2B, for example, that means that this patient is having stage 2 or he's having a 2 or more nodal groups either above or below the diaphragm, plus fever, night sweat, or weight loss. If you see someone being labeled as having 3E, that is to say this patient is having involvement of lymph nodes on both sides of the diaphragm, plus an extranodal involvement. If you see someone being labeled as having 3X, that is to say there is involvement of lymph nodes above and below the diaphragm, plus a bulky disease more than 10 centimeter or more than third width of the mediastinum. By this, we come to the end of our lecture. I hope you enjoyed it, and thank you very much for listening.